Hello, hello. Thank you for joining me for a brief lecture on cost, quality, and access. Welcome to Module 4. I just want to talk through a few of these slides and give you a little perspective. I apologize if my voice is not especially pleasing to your ears. I have been I've been sick for about 3 weeks, and I've been trying not to record a lot of these while I'm sick, but it is just not getting better. So this is the world we live in. So I will do the best I can to project and share and hopefully convey how excited and how passionate I am about the concept and the work that we do in healthcare quality. So in Module 4, we're going to talk about really common challenges that face healthcare administrators and how our knowledge of operational and financial structures can help us solve those challenges and how we can leverage systems thinking to generate practical solutions to do that work. Now, I want to just make a quick note as far as professionalism goes. It's really important that we enjoy what we do, that we communicate our passion. We don't look miserable as we're working through things. So these are two really cool stories. One of them is a 98-year-old physician, Howard Tucker. The other one is a 103-year-old who's said to be the world's oldest working architect. So take a look at these links. Hopefully, when you see them, they inspire you, they motivate you to think about what you can achieve in your career and having a life full of passion and fervor and positivity towards working in healthcare. On that note, let's talk about the more difficult topic of how expensive healthcare is in the United States. This is a view of life expectancy compared with specifically the amount of money that we're spending per capita, so per year, per an individual on healthcare services. And it can be really frustrating for many of us because we see the amount of money that is being spent in the United States and not a return on that investment, right? This is measured in 2010 international dollars, but it's just meant to show you the trajectory over time. We have not increased our life expectancy as much as other developed nations have. You can see Japan and Switzerland at the top. And we are spending much more per an individual, per capita on health services, right? So you can kind of see we're tapping out at about 79 years. And that's unfortunate. If we had the same return on investment as what we see for other countries, we would be spending closer to half of what we have been spending on health services versus spending, close to, I think, $10,000 now per capita per person on health services per year, and yet not seeing that benefit in life expectancy. So I want to talk about one specific challenge in healthcare and healthcare quality, and that's medical errors. Don Berwick, who was the founder of the Institute for Healthcare Improvement and the one-time head of the Center for Medicare and Medicaid Services, specifically said that in almost no other field, no other setting, no other type of business would consumers tolerate the frequency of error that is tolerated and common and pervasive. Sorry, I'm elaborating there, but common in medicine. And that was a New York Times article. From 2000 to 2010 alone, they did a study and medical errors were the cause of an estimated 250,000 deaths, just less than heart disease and cancer each. And I've seen some reports that say it surpasses cancer. If you know a little bit about my background, I'm a cancer survivor. I took care of my dad through cancer and he passed of oropharyngeal cancer. And both of us underwent medical errors while we were in the hospital during both sets of our treatment. And so it is far more common than we realize and can often be very hard to detect and respond to in a timely manner. Now, there is some future opportunities for AI and other technologies to help us address this, but it's still a current and future challenge. And how easy medical errors can happen. This is a quick story where a bronchoscopy was performed to remove a sunflower seed that went down a 2-year-old's airway instead of their esophagus. It was a doctor in New Mexico, and they inadvertently sedated the boy with an adult dose of morphine, caused him to stop breathing, led to permanent brain damage. Not a good situation. Then we have a lab in New York State that mislabeled a tissue sample, causing a woman who did not have breast cancer to get a double mastectomy while cancer kept growing inside of a woman who had the disease and didn't know it. Sometimes surgeons confuse right and left, right? Sometimes individuals suffer from overdose. This is a story with Betsy Lehman, who unfortunately died from an overdose of chemotherapy drugs that was miscalculated. Very common. I will tell you that I worked on a case with a hospital system that I worked with, and it's public knowledge. If you were to look, you could probably find it online, but they had a medical error that was disclosed where they diagnosed the wrong patient with colon cancer. They mixed up the samples from the colonoscopy and the biopsies, and the wrong patient was diagnosed with colon cancer. So this is not rare. It is incredibly common, again, in the health system. When we think about high costs of healthcare, on the next slide, we'll talk about a few more of these, but I want you, if you have a moment, and you can freeze this with video and go back and forth, to try to match each one of these statements to a cost containment issue. So if we talk about growth in technology, or let's go with the first one, third-party payment, insurers paying for healthcare, what cost increase does this lead to? Well, we've got number one, we just hired another billing specialist to help us deal with insurance denials. It could be that one. Could be the billing of a procedure in separate pieces because we don't get paid well. It could be number 5. I want you to go back and forth and look at some of these. These are decisions that are made that raise healthcare costs as a result, and I apologize, my fingers slipped there, as a result of the following practices. Waste and abuse, I think, would actually be that billing one with Medicare, right? But third-party payment means we have to have somebody do the billing, somebody double check on the billing. Growth in technology, for example, right? So it might be something like, we know our diagnosis is right, but I guess we have to cross our T's and dot our I's. That's actually, I think, defensive medicine. Let me see, did I put one in here for technology? Some of these are technology related, but they don't directly reference it. So take a look, see what you think is a match. What I want you to understand here is that there are many things that we do that raise the cost of healthcare, all because of we're trying to provide care within a broken system, and we're trying to do so for an elderly population in the medical model of healthcare delivery we currently have. So cost containment is really important. So if you think about going to school, going to college, $10,000 a year for 4 years, and how many kids you have? I have 3, and it's a lot more than $10,000 a year for what my kids wanted to do, but that's okay. Let's say that's $40K a kid, that's $120,000. In reality, it's probably closer to $30, $40K a year for my family. For like my son wants to go to school in California. So let's say it's $40K a year times 4 years, that's $160K per kid, times 3 kids, that's $500,000, $480,000. Now, when we think about healthcare, that 10K number, I'm using that on purpose, it's the healthcare number. That's our per capita healthcare spend. In some areas, it's closer to 12K. That's how much we could easily spend per person on healthcare in our current system, if we look at national health expenditures. That is a tremendous amount of money. So we have to work to try to limit that, because we are paying, taxpayers are paying that. The system is paying for that in different ways. We're leveraging national debt. Ooh, I don't want to think about that number. The other day I was thinking I should probably go in and see if I can find better updated debt data. And I said, you know what? I don't know that I want to look at this today for my own mental health and well-being. It's a lot of money. We're pushing, over 30 trillion in national debt. Okay. So let's say we're 31, 32 trillion. We're in the 30s for debt. And then we've got debt for individuals, right? We all have medical debt or personal debt, credit cards as we age, things, and hopefully you're financially aware. But this 93.8K per person is if we took the national debt and we allocated out per person how much money our government owes. And then, of course, if we allocate it out per taxpayer, because we don't owe taxes, that's $250,000 each. It's a lot of money. Now, we do a lot of things to control cost in healthcare. We do what's called utilization review, sometimes we call it health planning, where we limit or closely control what services are offered. We require pre-authorization for surgeries. We require sometimes utilization review requires concurrent review. So while someone's in the hospital, we're reviewing if the care is necessary, making sure they go home at the right time. Normally, these aren't market-based. It's insurers controlling it. It's not demand. It's not patient-driven. There's also different payment models that incentivize reduced utilization to try to cut cost. If we prepay a provider, they won't oversee their patients. They've already been paid. They won't oversee them in order to overbill. And then, of course, if we do a better job of managing patient illness with chronic disease prevention, chronic disease management, hopefully we can lower healthcare costs. Unfortunately, the underlying theme here, though, is that although we spend a lot in healthcare in the United States, many of us benefit from that. Some individuals receive excellent, superb, incredible care. Others do not. We have huge disparities, huge differences in access based on where you live, rural, urban, based on what you can afford, where you grow up, where you live, work, and play, right? When we think about social determinants of health, socioeconomic status, culture, and race, all of these things impact your ability to access health services. It's a funny quote from NASA. In God we trust, all others must bring data. When we look at the data, it tells a story, and it tells us that there is a reduced amount of access for many populations who can't receive the services they need, leads to avoidable ER visits, avoidable hospital admissions, and continues to drive up costs, that inequity that we have in our health system. Now, we've talked about healthcare quality a little bit by different area, right? So during the hospital lecture, for example, I talked about all the different hospital healthcare quality metrics. But quality provides us structure, key measures, metrics, indicators that we track over time. We have licensure, so physicians are licensed, hospital facilities, long-term care, skilled nursing facilities are licensed by the North Carolina Department of Health and Human Services. So licensure happens at the state level. And then we look at scope of practice. Are physicians doing what physicians should do? Is a nurse practitioner operating within, but at the top of their license, performing everything that they should be performing? We also have to think about communication and how that influences health. Translation services and understanding and health literacy, and realizing that who we are and how the amount of diversity in our nation means that outcomes can vary substantially. And if we want to reduce illness and hospitalizations and increase quality of life and increase lifespans, we have to do that for everybody. We have to restore equity and make progress together. So like I said earlier, outcomes can vary greatly. When we talk about the goal of vaccination, going back to 2021, when the COVID vaccination was first launched, right? What was the goal? To prevent illness, to keep us healthy, to get back to a new normal, right? But how we perceive that, how we react to that is different. Different belief systems, different political values. And so creating safety and quality healthcare can also be challenging for different reasons. It's not always clear what we should track, and it changes over time. I encourage you, if you have any time to view any of the videos from this lecture, take a look at this one. This is from Don Berwick. It's only 2 minutes long. It's in the PowerPoint posted, but it's a good overview of a good framework for how we should think about healthcare quality. And then lastly, we have here the triple aim. And this is from the Institute for Healthcare Improvement, the idea of increasing patient access and experience, improving population health and healthcare quality, and lowering the cost of care. Quite often I talk about cost, quality, and access, right? This kind of frames it under the guise of cost, health, quality, right? And access or experience. Are we getting the services that we need? All right, well, I hope this was helpful to hear a little bit about my perspective on the chapter. Please reach out with questions, and I hope you all have a great week. Thank you.